Hi there. My name is Hermine Creger, and I am faculty at Walden School of Nursing. And I wanted to talk to you about a case study involving a dermatological skin emergency. A 7-year-old boy presents to your office with reports of mouth pain and a new rash. So 2 weeks ago, you already saw this kid in your office, and at the time, he presented with fever, cough, and malaise and was started on amoxicillin for a presumed pneumonia. 5 days into his antibiotic course, he developed an itchy rash on his torso and palms, and he has new mouth sores. Mom is concerned about the marked diminished intake in the last 24 hours. He has no nausea or diarrhea, no vomiting. He's a healthy boy, and his vaccinations are up to date. His vital signs shows a temperature of 102, a heart rate of 122, a blood pressure of 119/73, and a respiration rate of 18. Your exam shows he's febrile, bilateral conjunctival injections, ulcers of the tongue and the lower lip, purpuric macular and bullae lesions on the face, torso, extremities, including the palms, mild diffuse cracked right lower lobe crackles, but no shortness of breath. Test that you did was a chest x-ray that showed right lower lobe infiltrate. His CBC was a normal white blood cell, and he has mild leukopenia. So let's look at what we know. We have fever, cough, malaise for 3 weeks. You have a mucosal and skin lesions that began while he was on amoxicillin and includes the mouth, the torso, and the hands. His x-ray shows a right lower lobe infiltrate, and he has cachexia. So what do we want to know? We want to know, when did this rash start and where did it start? Anybody else affected? Any sick contacts or animal contacts? History of food or medication allergies? Recent viral or bacterial eye infections? Any immune deficiency disorder? And recent new medication or medication changes. So let's look at the most common rashes that affects just the face itself. I'll start by directing you to look at the little fellow that we are seeing. So you can barely see it, but he does have red conjunctivitis. His eyes are red. He has lesions on his mouth, and then he has this macular rash on his skin. So anytime you have the mouth, you immediately think, well, is it hand, foot, and mouth? It's not, because it did not include his feet. Include his palms and his face, but not his feet. Below that, you've got herpes. Herpes doesn't have a macular rash. It's usually just a vesicular rash around mucosal areas. Impetigo is probable, but he doesn't have any honey-crusted lesions, which are the hallmark of impetigo. Eczema, bright red rash, but it usually does not include oral mucosa or the lips. Staph scaly skin syndrome is a probability because it does in fact affect the cheeks as well as the mucosa of the mouth, but it did not affect his eyes. He does not have conjunctivitis. And then lastly, it could be cellulitis. Again, cellulitis is infiltration of the soft tissue, hard and red, and usually doesn't have a rash associated with it. So if we looked at all our most important or common rashes, it's best that we review all our rashes to see if we can narrow this down. So first we have the macropapular rash, which is the red raised blotches, usually flat, can be confluent or satellite, and we usually see those in viral exanthems. He is febrile. Erythema multiforme, Mm, that can be a possibility. Lyme disease, he did not have a satellite lesion, or we can see it in Stevens-Johnson syndrome. Very possible because you have a rash as well as the mucosa of the mouth and the eyes affected. Petechial rashes are red blotches that kind of develop like capillary leaks. We usually see those in meningeal coccidemia, endocarditis, gonococcal disorders that progress into pustules. Less likely. Vesicles, those are usually fluid-filled lesions, less than 1 centimeters, but when it's greater than 1 centimeters, we call it bullae. He did not have any lesions, fluid-filled lesions, so the possibility of varicella, smallpox, hand, foot, and mouth, contact dermatitis, pemphigus vulgaris, or a burn is most unlikely. An erythematous rash is usually diffuse capillary congestion, and that is usually our viral syndromes like Kawasaki, scarlet fever. Sunburn can do it too, allergic reactions, toxic shock, pith disease, or roseola. So I think we go back to our first one and see if we can narrow it down as a maculopapular rash. So your differential diagnosis, either erythema multiforme or Stevens-Johnson syndrome. So this little graph compares the two really well. So erythema multiforme is usually herpes simplex or mycoplasma pneumonia. Now remember, you prescribed antibiotics for a presumed pneumonia, so it's still important to know. Whereas Stevens-Johnson syndrome is usually drug-related. It can be a medication. So the little fella on the left has papular erythematous lesions, where the lady on the right has macular lesions. Erythema multiforme usually is in 3 zones. So he's got it on the head, on the trunk, and the extremities. But Stevens-Johnson syndrome targets lesions are atypical. So not every child will present with the same distribution. Aerial distribution initially, which means it starts in one area and then it proceeds to another area, whereas Stevens-Johnson syndrome starts on the face and progresses to the proximal limbs initially. Here is important information. 70% includes mucosal involvement, but is limited to oral mucosa usually, just one mucous membrane. Whereas Stevens-Johnson syndrome has 90% mucosal involvement and many or more than one site. And that can be the eyes, the mouth, the nose, or the rectal area. So another big differentiation is Stevens-Johnson erythema multiforme is usually 10% of the body surface, whereas Stevens-Johnson syndrome is extensive with epidermal necrolysis. So these lesions are much more aggressive. Erythema multiforme is a mild course, usually resolves in 1 to 4 weeks. And recurrence are common, and many are herpes simplex related. Whereas Stevens-Johnson syndrome or TENS is high mortality in severe cases, up to 5%, and it's uncommon that it would reoccur unless you reintroduce the same drug again. So our diagnosis then is Stevens-Johnson syndrome. It is a rare type 4 hypersensitivity reaction with sheet-like skin lesion loss. The rash typically affects less than 10% of the total body surface, but it can be more than 10, and then we are looking at epidermal necrolysis or TENS, and that is a far more serious progression of the presentation. So, Stevens-Jones syndrome is a clinical diagnosis. It is made in any patient with a suggestive history, prodromal symptoms, and a characteristic skin and mucosal membrane lesions. So, risk factors. Medications is the number one. Anticonvulsants like carbamazepine or phenytoin particularly look at the child that was recently diagnosed with seizures and started on seizure medication. Antibiotics, penicillin, cephalosporins, and sulfonamides are high on the list. Sulfonamides is the most common. Non-steroidals, children's Motrin can cause this. So make sure you tell your children, your parent, when you start them on Motrin. Viral infections including Coxsackie virus, EBV, herpes, HIV, mumps, influenza, pneumonia, and CMV. All of those can trigger it. Bacterial infections are usually strep, mycoplasma pneumonia, and brucellosis. And then it's also significant that it's usually prominent in Asian descent and also in females. So SJS is a medical emergency and therefore requires prompt recognition. So here are the key findings to look for. Be suspicious of a drug eruption that starts 2 weeks after the start of a new medication. There will be a prodrome of fever and flu-like symptoms a few days prior to the appearance of the maculopapular rash, including skin paresthesias, tongue and lip swelling, and a palpable purpura. Then there is the rash. Typically starts on the face and progresses to the trunk and may include the palms, but not the soles. Rash may progress to sloughing of the skin, and that's Nikolsky sign, and you can see that on the left where it just peels away if you touch it. And then it affects two mucous membranes. In our case, it was the eyes and the mouth, but it can be the eyes, the lips, the mouth, the airway, the esophagus, the gastrointestinal tract, and the anogenital mucosa. Treatment, immediate referral for hospitalization, and a Scorton score done for severity. That will predict your course of treatment and also severity of the disease. Immediately stop the presumed inciting medication. Management for CJS is similar to the treatment of major burns with supportive care that include fluid and electrolyte replacement, nutritional support that may require NG feeds, and a comprehensive wound care plan and pain management. These children are sick. There also should be a formal ophthalmologist evaluation to treat conjunctivitis and to avoid cataracts and blindness, and may require ocular steroids and antibiotic drops. Treat the ongoing infections, in this case the pneumonia, and monitor for superimposed infections like Staph aureus and herpes. Sepsis and bacteremia is the leading cause of mortality, more than 5% in some cases. Other complications to look out for is ARDS and organ dysfunction. So the long of the short is, this child should be immediately transferred to the emergency room for evaluation and admission. This is not something that you think you can treat in the office. Mortality is very, very high. So to end with, I always say never neglect details. When everybody's mind is dulled or distracted, the leaders must be doubly vigilant. Colin Powell said that, by the way. Thank you very much for your time, and I hope that you will learn something from this.